Hello, everybody. My name is Catherine Aquino, and I am a PGY1 pharmacy resident here at Loma Linda University. And today I will be talking about pulmonary tuberculosis. So, TB can affect other parts of the body, but for the purposes of this lecture, we will be focusing on the lungs. So by the end of this lecture, my goals for you guys are as follows. So explain the pharmacologic action of antimycobacterial agents, describe the clinical presentation of active pulmonary tuberculosis, design a medication regimen for patients with latent TB based on the CDC guidelines, design a medication regimen for patients with active pulmonary TB based on the IDSA guidelines, incorporating first and second line treatments when necessary, use imaging and laboratory values to monitor efficacy and safety of antimicrobacterial agents, and counsel patients on the proper use of antimicrobacterial agents. So here are the guidelines that I used for this lecture. So we have the CDC guidelines and the IDSA guidelines. So what is pulmonary tuberculosis? So it's lung infection caused by Mycobacterium tuberculosis, and it's transmitted by airborne particles when infected persons cough, sneeze, shout, or sing. So here is a map from the CDC about the estimated tuberculosis incidence rates in 2021. So you can see here that we do not have as many cases here in the US. Most cases occur in Africa and in Asia. And so this is something I want you guys to keep in mind when you assess patients. So if patients say that they recently traveled to the area shaded with the darker green, then your suspicion of TB might be higher if they are presenting with symptoms. So how does someone get pulmonary TB? So first, TB is transmitted via droplet nuclei when an infected person coughs, sneezes, etc. Then another person would get infected if they inhale the droplet nuclei. Then the bacilli then travel to the alveoli in the lungs. Then your macrophages and the alveoli will ingest the bacilli and form a granuloma, which essentially sequesters the bacteria, keeping them from multiplying and spreading throughout the body. So now if it all stops here, then the patient gets latent TB. But if the granuloma breaks down, the bacilli can multiply and spread, causing active tuberculosis. So here are the differences between latent and active pulmonary TB. So for latent TB, as mentioned earlier, the bug has basically been contained by the immune system in the granuloma, but in active TB, the infection basically, it overcomes the immune system and the granuloma breaks down. Patients with latent TB are not infectious, while patients with active pulmonary TB are infectious. Patients with latent TB have normal chest X-ray, while those with active TB have abnormal chest X-ray. And I'll go into what you guys will expect to see in chest X-rays for patients with TB. And for latent TB, this is detected by the tuberculin skin test, or the TST, and or also the interferon gamma release assay, or the IGRA. And then for active TB, these are diagnosed with a positive culture and acid-fast bacilli smear. For patients with latent TB, they do not have to be in respiratory isolation, but for those with active pulmonary TB, respiratory isolation is required. So TB patients will have to be placed in negative air pressure rooms. So this is to ensure that the air from the patient room does not escape out into the other patient areas. So the rooms will have an anteroom where nurses and other healthcare providers can wear their PPE prior to entering the patient's room. So this is all part of infection control. And you won't find TB patients in regular patient rooms for that reason. And just note that patients with latent TB, they can progress to active TB at any point in time. So these are the signs and symptoms of active TB. So patients can present with coughing that lasts for 3 or more weeks. They can have hemoptysis, or coughing up blood. They'll show up with fever, night sweats, fatigue, unintentional weight loss, chills, loss of appetite, or chest pain or pain with breathing or coughing. And here are the diagnostics for TB. So we have the acid-fast bacilli or AFB smears, and this is to detect the presence of mycobacteria, and this one is conducted on sputum samples. So we cannot use gram staining in TB patients because the bacteria don't show very well on gram stains because of the presence of mycolic acids, which are part of their cell wall. We also have the mycobacterial culture, which is used to detect the presence of mycobacteria, the diagnostic nucleic acid amplification test, or the NAAT. It's a rapid test to identify the genus and species of the bacteria. And then there's also the chest X-ray, which is used to detect lung damage. And the damage will mostly be asymmetrical. So meaning one lung or one side will have more damage than the other, and it's usually in the upper lobes for adults. So you can also see cavitation in the chest X-ray for these patients. So let's get into our first-line treatments for pulmonary TB, and the acronym for the regimen is RIPE, which stands for rifampin, isoniazid, pyrazinamide, and ethambutol. So let's start with rifampin. This works by inhibiting RNA polymerase, and notable adverse reactions include hepatotoxicity and a red-orange discoloration of body fluids. And it's really, really important to know that this is a strong CYP3A4 inducer. So definitely something to look out for when you guys are assessing patient med lists. Make sure that this doesn't have any drug-drug interactions. And there's also isoniazid, which is a prodrug, and it's activated by catalase peroxidase, which inhibits the biosynthesis of mycolic acid, which again is part of the mycobacterial cell wall. Notable adverse reactions include hepatotoxicity and peripheral neuropathy. And so patients taking isoniazid will also be on pyridoxine or vitamin B6. And this is to prevent peripheral neuropathy, and it's dosed at 25 to 50 milligrams once daily. And we also have pyrazinamide, which is converted to pyrazinoic acid, but the exact mechanism of action is unknown. Notable adverse reactions include hepatotoxicity. This is the most hepatotoxic out of the RIPE therapy agents, and it can also cause hyperuricemia. And there's also ethambutol, which inhibits arabinosyl transferase and prevents the formation of the cell wall. Notable adverse reactions include optic neuropathy, hyperuricemia, and peripheral neuropathy. And it's important to know that this one can cause irreversible blindness in patients. So it's really important if patients experience any changes in vision that they report this to their doctors. So now we go into our second-line therapies for tuberculosis. We use these medications when patients cannot tolerate the first-line agents or if resistance occurs. So the first one that we have here is amikacin, which is one of the aminoglycosides. This inhibits protein synthesis by binding to the 30S subunit of ribosomes, and it can cause nephrotoxicity and ototoxicity. There's levofloxacin and moxifloxacin. These inhibit DNA synthesis by binding to topoisomerase 4. And adverse reactions include tendon rupture, peripheral neuropathy, QT prolongation, and phototoxicity. And then there's also linezolid, which inhibits protein synthesis by binding to the 50S subunit of ribosomes. And a big adverse reaction for this is myelosuppression, primarily thrombocytopenia. And this one can cause serotonin syndrome, and it can also be used for multi-drug resistant tuberculosis or MDR tuberculosis. So there are many other medications that can also be used for multi-drug resistant tuberculosis, and the IDSA has a separate guideline for this, but this is beyond the scope of this lecture. And I also wanted to highlight the two other rifamycins that we can use in tuberculosis aside from rifampin. So we have rifapentin and we have rifabutin. So of these three, rifabutin has the longest half-life at 45 hours. And the most potent CYP3A4 inducer is rifampin. So it's really important to remember. And the least potent is rifabutin. For rifapentin, it's dose dependent. So make sure you think about these concepts when you select the appropriate rifamycin for patients who are taking other medications that are CYP3A4 substrates. And lastly, I have the doses in the bottom row. So it's really important to note that rifabutin or rifapentin can be used in place of rifampin when there are significant drug-drug interactions in a patient's med list. So I have here the 4 regimens that patients with latent TB can take. So there's isoniazid and rifapentin once weekly for 3 months. There's isoniazid and rifampin once daily for 3 months. There's rifampin once daily for 4 months. And there's also isoniazid once daily or twice weekly for 6 or 9 months. And of these, the combination regimens at the top and rifampin monotherapy are listed as preferred regimens in the CDC guidelines. So here I have the treatment for active pulmonary TB. So the intensive phase is done for 8 weeks, and the continuation phase is done for 18 weeks. So all medications are dosed by weight and are listed here for your reference. So don't forget to add pyridoxine when a patient is also taking isoniazid. So now it's also very important to note that once the bacteria are shown to be drug susceptible, meaning that it is sensitive to all the first-line treatments, then you can discontinue ethambutol even before the 8th week of the intensive phase. So if you notice here, patients will be on all 4 drugs basically for the intensive phase unless it's drug susceptible. Then you can DC ethambutol before the end of the intensive phase. And once a patient is in the continuation phase, then they will only be on 2 drugs, so rifampin and isoniazid. So what do you monitor to assess for safety? So because we have a lot of hepatotoxic drugs, we monitor the LFTs. So you have your AST, ALT, and T-bili. You want to monitor your kidneys, so BUN and serum creatinine. For CBC, you want to monitor the platelets in particular. So this is important for linezolid and then for rifampin as well, and you'll see that in a little bit. And for ethambutol, you want to check the eyes because of the irreversible blindness that it can cause. And lastly, you want to monitor for toxicity from drug-drug interactions, and this is primarily for rifampin because it is a strong signal. And what do you monitor to assess for efficacy? Basically, you want to watch for resolution of symptoms, and you want to see improvement in the chest X-ray, and you also want the AFB smear and cultures to be negative. So here's a sample of what one might use to monitor patients being treated for TB. So you want to maintain regular follow-up with these patients to ensure proper adherence and understanding of their treatment. So because the therapy is for such a long time, patients can be at an increased risk for adverse effects. And they may also start feeling better even before the end of treatment. So some patients might not see the need to continue taking their medications. So it's really important to remind them to finish their course to prevent the return of infection and prevent resistance. And you guys can see here that for baseline checkup, for example, the clinician will monitor all of these, conduct some lab testing, and then monitor them on a monthly basis, just to make sure that patients are getting better and they're not at risk for these hepatotoxicities or other toxicities from taking these drugs for a really long time. So how do you manage toxicities when they occur? So let's start with GI upset. So for this, patients can use antacids or proton pump inhibitors, and patients can also eat a light snack or low-fat food with their medications to help with the GI upset. When it comes to rash, if there is no systemic involvement like fever, then patients can use antihistamines. If patients have petechial rash, this is essentially hypersensitivity to rifamycin. This can show thrombocytopenia, and that's why you want to monitor the CBC for these patients. If this happens, make sure to discontinue the rifamycin that they're taking and monitor the platelet count. If patients have Stevens-Johnson syndrome or TEN or DRESS, make sure to discontinue the offending drug. If patients have hepatotoxicity, so that basically means having an ALT of at least 5 times or more of the upper limit of normal, with or without symptoms, so with or without jaundice, etc., or if the ALT is greater than or equal to 3 times the upper limit of normal with symptoms, then you want to discontinue the hepatic drugs. Um, and if patients have disproportionate increases in bilirubin or alk phos compared to ALT, then this is likely a rifampin hepatotoxicity. Once the ALT returns to less than 2 times the upper limit of normal, then clinicians can restart the hepatotoxic drugs sequentially. So there's an important order for this one. So you want to restart rifampin first, which is the least hepatotoxic among the first-line agents. If the patient does not have any signs of hepatotoxicity after 1 week of being back on rifampin, then you can restart isoniazid. And after 1 week, if the patient's still okay, then you can restart pyrazinamide. So basically, you want to, once you see the ALT starts to increase, discontinue the hepatotoxic drugs, and then the LFTs will start to come down gradually. Once the ALT returns to less than 2 times upper limit of normal, restart the drugs as written here. If pyrazinamide cannot be restarted due to hepatotoxicity, then you can just extend the regimen to 9 months. So basically, that's 2 months of the intensive phase, so 2 months of rifampin, isoniazid, and ethambutol, followed by 7 months of rifampin and isoniazid. For optic neuritis, you want to discontinue ethambutol. If the patient does not have any improvement after discontinuing ethambutol, then you can discontinue isoniazid. Instead of those drugs, patients can just be on moxifloxacin or levofloxacin instead. So lastly, these are the counseling points that I'd like you guys to be aware of. So patients should report signs or symptoms of liver problems. So that's evidenced by dark urine, light colored stool, or the yellowing of skin or eyes. And for right therapy, it's important to remember that rifampin and isoniazid must be taken on an empty stomach. And for the others, it doesn't matter. It's also important to note that rifampin can discolor body fluids and also contact lenses. And for isoniazid, patients can experience peripheral neuropathy, and that's why they have to take pyridoxine or vitamin B6. For pyrazinamide, it can exacerbate gout, so definitely something to monitor if patients have past medical history of hyperuricemia or gout. Lastly, make sure patients know to contact their providers if they experience any vision changes while taking ethambutol. All right, thank you guys so much for your time, and email me if you have any questions.